Thank you, sir. It's a pleasure to be here. And I'm going to talk about how to simplify basal bolus therapy and using some case nuggets, the role of flexible insulins in hospital. Now, we know that hospital hyperglycemia is completely different. There are different challenges and different things. And these challenges are very intricate because one of the challenge is that 30% of non-critically ill hospitalized patients with or without diabetes, they have hyperglycemia. And why we should treat it, this hyperglycemia is associated with more complications, more length of stay, and more mortality. So that is the reason why we should treat in hospital hyperglycemia. And there are guidelines for it. The definition of in-hospital hyperglycemia in 2025 is any blood glucose level more than 140 that has to be treated, and if the admission HbA1c is more than 6.5, that means it is not a stress hyperglycemia. The patient probably already has diabetes and you can diagnose diabetes and start treatment. Of course, all this is not needed if the patient is already a known diabetic and is going to take is already on medicines, like I will discuss a case at the end of my presentation. When to start insulin? I think the most important number to remember is if the blood glucose level is more than 180, you need to start insulin for your patient. What is the range at which we should keep the blood glucose levels in non-critical settings? Well, the range is 100 to 180. Some people would say 70 to 180, but 100 to 180 is a reasonable range. If your patient is going to undergo, say, CABG, cardiac surgery, then maybe 110 to 140. As you know, in the ICU, we try to keep it between 140 to 180 and not below that. And we need not attempt tight control in every patient. For example, a terminally ill patient dying of cancer, elderly people who are on a do not resuscitate category. In those patients, the goal of therapy is only to give enough insulin to prevent ketosis and minimize the symptoms of hyperglycemia. And there your cutoff becomes 250. Below 250 is okay. This is also true for people on dialysis in hospital because, as you know, dialysis itself causes hypoglycemia, and therefore in hospital dialysis that goes on, I think the cutoff has to be below 250. So therefore, friends, I introduced you to the concept and I showed you how in-hospital hyperglycemia is different game with different rules. Now let's look at degludec, which is probably the most ideal insulin to use in a hospital. One of the reasons is it acts faster than glargine. We think of basal insulin as acting in 1 to 2 hours. That's not so. Glargine takes 2 to 4 hours to act, and U300 can take up to 2 to 6 hours to act. So for in-hospital use, where you want a reasonably quick action, remember, when you are stopping an insulin infusion, before that, you should give the degludec injection an hour before or so. But if you are looking at glargine, you may have to give that injection 2 to 4 hours before so that it acts exactly when the insulin infusion stops, the insulin is ready to act. So that is the practical aspect of why degludec is a little better in that sense. You can also see the study where in-hospital subjects were randomized to either degludec or glargine U100, and you can see the blood glucose levels coming down very well with degludec. There are two interesting papers which looked at titration of insulin in the hospital setting. What is the difference between these papers? The first paper compared degludec to glargine U300. The second paper compared degludec to glargine U100. So one was from India, one was outside India, but both are excellent papers. And what the Indian study was probably a better study. It showed that it compared degludec with glargine U300. So these are comparable ultra long acting basal insulins. What this study showed is that the glucose control was better. The fasting glucose control was better with insulin degludec, and this was statistically significant. Now you can see that the difference is not much, but the important question is, did degludec achieve this degree of fasting glucose control with hypoglycemia or without hypoglycemia. The important thing is that this statistically significant improvement in fasting was not associated with any severe hypoglycemia in these papers. So that is the reassuring data. And you'll also see that uh, if you look at flexibility for a basal insulin, degludec is the one with the most flexibility. You can inject it between 8 to 40 hours. Glargine U100 has really no flexibility, and Glargine U300, there's about a 3-hour time period. So therefore, friends, degludec is a quick onset of action, quicker than Glargine. It is a flat, peakless, better fasting glucose control without hypoglycemia. In hospital we are talking about, and of course the variability is minimal and there is good flexibility of dosing. Now let's look at another insulin which we can use in hospital, which is the ultra fast insulins, which are basically, we are going to talk about faster acting aspart. We know that you have regular insulin and you have the normal pancreas producing insulin, and you have the ultra fast acting insulins like faster acting aspart and ultra rapid lispro insulin. Now these insulins deliver more amount of insulin in the first 30 minutes. That's why you get more insulin. So the postprandial control is better. And because the insulin delivery is so instantaneous, the patient can take it before, during or after, as I will discuss. So, sorry. Many people ask me, why is niacinamide added to insulin to make it fast? Well, the reason why niacinamide is added is only because it causes a more rapid dissolution or dissociation of aspart hexamers to rapidly absorbable monomers, so that the subcutaneous injection depot is quickly absorbed. And that is the reason you have a different insulin. And you can see many people think that faster acting aspart only controls the 1-hour glucose, but it also controls the 1-hour and the 2-hour, and it is superior to other insulins. The very important thing is that when you have a patient in hospital and you're treating that patient, now you have given the insulin and the patient had lunch. Now the patient has gone to some other department for an MRI or an X-ray or a CT scan or ultrasound. There, the patient may get a hypoglycemia, and the staff there, of course, should be trained to look after, but you'd want to prevent that hypoglycemia. And that is why delayed hypoglycemia is very important in a hospital setting. And here is a study that if you look at faster aspart, it reduces hypoglycemia, whether it is within 4 hours, between 2 to 4 hours, between 3 to 4 hours. It reduces the occurrence of delayed hypoglycemia, because unlike the regular insulin, which lasts for 6 to 8 hours, this is going to last only for a short period. So it will cover the glucose taken in the meal. So after that, the patient will not get hypo. Of course, the patient may require correction factors later, but this delayed hypoglycemia, very important in a clinical setting, will not happen with faster acting aspart. Like degludec, aspart, the faster acting aspart also is quite flexible. You can inject it 2 minutes before a meal to 20 minutes after a meal. This is most convenient in daily life, but it is more even better in hospitals, because supposing the patient has come back late from an endoscopy or an ultrasound or an X-ray, and the meal is got delayed, and on the way patient was hungry, so the patient already ate something. Now the patient has reached the room. Okay, if it is within 20 minutes, you can still give you a dose of aspart. So that is the advantage of that, and you can titrate accordingly. It doesn't become a correction bolus, it becomes a meal bolus. And therefore, it can also reduce the risk of hypoglycemia if the meal is delayed. And it's also useful for patients with irregular eating parameters. Sometimes you don't know if your renal failure patient is going to eat today lunch or not. So you can tell the nurse that you can see how much he or she is eating. A patient is eating less, you can give a little bit less aspart after the meal also. You can decide. So that is the advantage of in-hospital aspart use, faster acting aspart, because you can give it just before, during, or even after the food. So you don't have to sit and worry insulin. If I give the insulin, if the patient doesn't eat, gets hypoglycemia, that issue is not there, because you can even tell your nursing staff to inject it after. Well, this means we should train the nursing staff, but all in all, you have a faster acting faster acting insulin aspart is obviously faster. That is why its name is faster, but it delivers more insulin early. So it has an earlier peak and a short duration, which means it comes in and goes out quickly, and therefore there is less chance of delayed hypoglycemia. As I mentioned, in hospital where you require some flexibility, minimal hypoglycemia, patient is undergoing a lot of things. This gives an advantage to your patient. So we've talked about hospital hyperglycemia, different game with different rules. We've talked about degludec for in hospital. We've talked about faster acting insulin aspart in hospital. Now we will look at the bedside application of these discoveries. Let's look at a patient. Mr. Rajesh, 52 years old. He's a teacher, 75 kilograms. His BMI is 25. He's got admitted for 5 days history of fever, tiredness, reduced appetite. It could be a viral fever, it could be dengue or something like that. The HbA1c is pretty high at 10%. The fasting is 216. Now the high HbA1c tells you that this is not just because of fever. His glucose has been uncontrolled even before. This suggests to you that even after his discharge, he may require additional therapy. So he was on metformin, glimepiride and sitagliptin, and now he's in hospital and the sugars are all 200 plus. So therefore his diagnosis is here pneumonia. It could be, like I said, a viral pneumonia, and he's on IV fluids, supportive medications. You need to stop the oral drugs in these patients, because if it was a dengue and you're expecting a short admission, you can even continue OHS for 1 or 2 days, doesn't matter. But here, it's a pneumonia, he's going to have antibiotics, he's going to be in hospital for quite a time. So you have to stop all the OHS, you have to give him insulin. And the ideal is to give basal bolus regimen. As you know, he is not sick enough. If he was sick, you would have had to give him intravenous insulin infusion protocol. But he's not sick, so he's not that sick, doesn't require ICU. So he's about eating, so basal bolus is okay. So this gentleman is on basal bolus insulin, and you can see that this is the insulin dosing on day 1, and these are the blood glucose on day 1. Simple steps in adjusting the glucose based on by adjusting the insulin will really help the glucose control to be good. You can titrate the degludec and the 5-ASP together similarly like you titrate any daily insulin, and you will still get the good control. So friends, you can use any basal insulin. You can use degludec, you can use glargine U100, you can use glargine U300. But if you want to choose an ideal basal insulin for in-hospital use without hypoglycemia to cover for the uncertainties in a hospital, then it should be degludec. You can use any rapid-acting insulin. You can use regular, you can use Lispro, but if you want to use an ideal one, it is faster-acting insulin aspart. And this is his discharge. As I said, he's on a small dose of insulin degludec, and you can adjust it after diet and exercise as time goes by. So degludec and aspart together give you a very potent mechanism of action to control the blood glucose levels in hospital. Friends, it was a pleasure discussing this topic with you, and thank you for listening to me.